Hello everyone. After discussing the basics of megaloblastic anemia, now let us discuss about the vitamin B12 metabolism. First, we'll start with the vitamin B12 absorption. So, as you all must be knowing that vitamin B12 is only present in the food of animal origin. Okay, so that means the vegetarian foods will lack vitamin B12. Okay, so that is why vegetarians are prone to develop B12 deficiencies. What is the normal daily requirement? So normally we need only 3 microgram per day. And how much store we have? The store we have is around 3 milligram. And even if you stop taking vitamin B12, that means even if you stop taking the non-vegetarian food items, this store is sufficient for at least 3 years. Okay, so this store is sufficient for at least 3 years, even if you don't take vitamin B12. Okay, so only after 3 years of stopping non-vegetarian food items, you are going to develop significant B12 deficiency. Okay, so this is very easy to remember. Daily requirement is 3 microgram, storage is 3 milligram, and it is sufficient for 3 years. Now we'll see how it is getting absorbed. So in the diet, vitamin B12 is present by binding to certain proteins. Those are known as vitamin B12 binding proteins. Okay, after it is getting ingested, what happens inside the stomach? Inside the stomach, we have chief cells. So these are C means these are chief cells. And P is parietal cells. Okay. So what happens? These chief cells will produce pepsin. So it will produce pepsin. Actually, it will produce pepsin in an inactive form that is known as pepsinogen. Okay, that is known as pepsinogen. And that pepsinogen will be activated by the hydrochloric acid that is present in the stomach. And the hydrochloric acid is produced by the parietal cells. Okay. So these points are important to remember. So we have chief cells which will produce the pepsinogen that will be activated by hydrochloric acid, which is produced by the parietal cells. And this active form is known as the pepsin. Okay, so pepsinogen will be converted to active pepsin molecule. Now, this pepsin can actually cleave vitamin B12 from its binding protein. Okay, so this pepsin, this will cleave the vitamin B12 from its binding protein. Now, this vitamin B12 is free and it will bind to something known as haptocorine. Okay, so haptocorines are actually produced from the salivary gland. Okay, so salivary glands will produce haptocorines, and these haptocorines will come to the stomach. In the stomach, after the vitamin B12 is released from the binding proteins, these haptocorines now can bind to, it can now bind to the vitamin B12, as you can see here. Okay, so chief cells will produce pepsin, and parietal cells will produce hydrochloric acid, and along with that, it will also produce intrinsic factor. Okay, so parietal cells will produce intrinsic factor and hydrochloric acid, and chief cells will produce pepsin. Now, what happens? Now, this B12 binding to haptocorine and the intrinsic factor, both of them will go to the, small intestine, especially to the duodenum. Now, here in the duodenum, you can see the pancreas is releasing the pancreatic enzymes, or it is known, these are known as the proteases. They will release the pancreatic proteases. Okay, so these are the pancreatic proteases. Now, what is the function of these pancreatic proteases? Now, these proteases can actually release the vitamin B12 from the haptocorines. Okay, so they'll cleave the association between haptocorine and vitamin B12. Now, again, the vitamin B12 is free. Now, this vitamin B12 can actually bind to the intrinsic factor, which is coming from the stomach, from the parietal cells. Okay, so B12 is now free from the haptocorine because of this pancreatic proteases. Now it will bind to the intrinsic factor, and this intrinsic factor B12 combination, this complex will go to the ileum. Okay, so this is actually ileum, and ileum is the site from where this intrinsic factor and B12 combination is going to get absorbed. Okay, so we discussed when we discussed about the iron metabolism, iron absorption, I have told you that iron is predominantly absorbed in the duodenum, but vitamin B12 is predominantly absorbed in the ileum. Okay, after this, we'll discuss about the folic acid metabolism, and folates are predominantly absorbed in the jejunum. Okay, so how exactly it is absorbed? Actually, in the ileum, we have some receptors. These receptors are actually known as cubam receptors. Cubam receptors. Okay, this cubam receptor is actually a complex of, it is a complex of tubulin and another protein that is known as amnionless. Shortly we can write as AMN. Okay, so this is actually amnionless. This amnionless will be bound to this tubulin receptor, something like this. Okay, so this tubulin and amnionless, they will make a receptor complex for this intrinsic factor and B12 complex. This tubulin will have the receptor. This tubulin will have the receptor for the intrinsic factor. Okay, so that the intrinsic factor can bind to this tubulin receptor. Okay, so tubulin molecule will have receptor for this intrinsic factor. Now this intrinsic factor will get bind to the tubulin. Then what is the function of amnionless? This amnionless will help in endocytosing this complex. This receptor ligand complex can be endocytosed by this amnionless. So that is the function of amnionless. Okay. So the receptor complex is known as Q1 receptor complex. It will have two components. One is tubulin, which actually has the intrinsic factor receptor, and it will have another molecule that is amnionless, which helps this receptor ligand complex to be endocytosed. Okay, after the complex is endocytosed, now the intrinsic factor will be released from the vitamin B12, and this B12 can go into the circulation. In the circulation, it will bind to another protein that is known as transcobalamin 2. Transcobalamin 2. Okay, so trans means transporting. So transporting cobalamins, that is why the name transcobalamin. Similarly, what we have discussed for iron, that was transferrin. Similarly, here it is transcobalamin. Especially the transcobalamin 2 that will bind to the vitamin B12 molecule, and it can go and supply to various organs. Okay, and especially it will go and supply to, it will go and provide this vitamin B12 to liver, bone marrow, because in the bone marrow we have this process of hematopoiesis, and that needs a lot of this vitamin B12 for this effective DNA synthesis. So that will go to the bone marrow, and also it will go to the gut, to the GIT, because in GIT also they have this rapidly proliferating, because the GI epithelial cells will have a higher turnover. Okay, so they are also rapidly proliferating cells. They also need this vitamin B12. Okay, so GIT, bone marrow, and liver, these are the sites to which this vitamin B12 will go. Okay, and liver is the predominant storage site for the vitamin B12. Okay, so this is about the normal vitamin B12 absorption. One more point I wanted to tell is there is something known as transcobalamin 1 also. Okay, as we are discussing about the transcobalamin 2, but what about transcobalamin 1? Now this transcobalamin 1 can also bind to vitamin B12. It can also bind to vitamin B12. However, this will not release the B12 into the tissues. Okay, so whatever B12 is bound to transcobalamin 1, it will remain in the circulation. So it will remain in the circulation itself, and it will not be provided to the tissues. So they will not give this B12 to the tissues. Okay, why I am telling this? Because in patients, for example, in patients with CML, okay, before that I must tell this transcobalamin 1 is released predominantly from the neutrophils. Predominantly it is released from the neutrophils. Okay, so sometimes it is described, especially in the patients with CML, where this neutrophil or neutrophil precursors are increased. You can also find the vitamin B12 binding proteins increased, and also the vitamin B12 levels are increased in this condition. Okay, so many times in the books you must be studying that in CML, in patients with CML, the vitamin B12 levels are increased, and this is the reason why the B12 levels are increased in the serum, because the transcobalamin 1 levels are increased because of increased neutrophils, and that will hold the vitamin B12 and it will not provide to the tissues. So that is why in the circulation the B12 levels are increased. Okay, so that is why I told about the transcobalamin 1. Other than this concept, there is no need to remember about transcobalamin 1. Okay, now there is one more form of absorption. This is what is a very regulated form of vitamin B12 absorption, but there is one more form, that is the passive absorption. That means vitamin B12 can also be absorbed passively without help of any of these things. However, this will absorb only very minute amount of B12, and it is really, I mean, it's very inefficient. Okay, so this passive absorption is actually very inefficient. However, if you give a very large oral dose of vitamin B12, then this passive absorption will become somewhat significant. Okay, so only if you give a very high dose of vitamin B12 orally, this passive absorption will become significant. Otherwise, it is really inefficient and it is not significant. Again, why we are discussing this concept? Because in patients, we'll discuss later, in patients with pernicious anemia, there is atrophy of there will be atrophic gastritis. Okay, so there will be defective absorption of vitamin B12 through this process. In those patients can also be treated with oral vitamin B12 if you give vitamin B12 in a very high dose. Okay, so if you give vitamin B12 in a very high dose, you can treat those patients because they will still have this passive absorption mechanism that is not affected in patients with pernicious anemia. Okay, so that is that is the reason behind telling this concept about vitamin, this concept about the passive absorption. Other than that, passive absorption is really insignificant and it's not sufficient to cause any significant absorption unless you give a very high dose of vitamin B12. Okay, so again, I just repeat the absorption process again, because when we will discuss about the causes of B12 deficiency, again, this concept will come. Okay, so vitamin B12 will be bound to B12 binding protein in the food items. After it is taken into the gut, inside the stomach, this B12 will be released from the binding protein with the help of pepsin. And pepsin is released from the chief cells in the stomach, but it will be released in the inactive form that is known as pepsinogen, or the precursor form that is known as pepsinogen. That pepsinogen will be active with the help of hydrochloric acid, which is produced from the parietal cells. Okay, so parietal cells will produce hydrochloric acid, which will convert pepsinogen to pepsin. Okay, that is the active form. Parietal cells will also produce intrinsic factor. Okay, now this pepsin will cause release of B12 from the B12 binding protein. Now this B12, which is now free, it can bind to something known as haptocorins. Okay, haptocorins are released from the salivary gland. Okay, so haptocorins are released from the salivary gland, and this vitamin B12, which is freed now from the binding proteins, it can bind to haptocorins inside the stomach. Okay, now this combination, along with the intrinsic factor, they will go to the duodenum, where the pancreatic proteases will come into action. They will release the vitamin B12 from the haptocorins. Once B12 is free, it can bind to the intrinsic factor, which is coming from the stomach parietal cells. Okay, now this complex of intrinsic factor with vitamin B12 can go to the ileum, where this intrinsic factor receptors are present, and these receptors are present. I mean, the name of the receptor is tubulin. Okay, name of the receptor is tubulin, and this tubulin intrinsic factor complex can be endocytosed with the help of another protein that is known as amnionlase. Together, this tubulin and amnionlase are known as cubome receptor. Okay, so in some books they will write tubulin, and some books they will write cubome receptor. Okay, so after getting endocytosed, again this intrinsic factor will be released, and this vitamin B12 will be free. Now this free vitamin B12 will go into the circulation, and they, in the circulation they will bind to transcobalamin 2, and along with this transcobalamin 2, it can go into various cells, various tissues in our body. Especially they will go into the bone marrow for erythropoiesis, for hematopoiesis, and they will also go to the gut for the rapidly proliferating epithelial cells, and they will also be stored in the liver. Okay, so this is about the normal absorption, and also I told daily requirement is 3 microgram, storage is 3 milligram, and sufficient for 3 years. Okay, now that we have understood the mechanism of absorption in detail, now actually we can tell what are the causes for vitamin B12 deficiency. Okay, now let us see what are the causes for vitamin B12 deficiency. It can be divided into 3 groups. The first one is decreased intake, second one is decreased absorption, and third one is increased requirement. Okay, so decreased intake, as we know, it is found in vegetarians. It is found in vegetarians. That is very obvious to understand. Again, some patients who are like malnourished, who have a poor diet, they can also develop this vitamin B12 deficiency. However, vitamin B12 is required a very minute amount, that is only 3 micrograms. So usually the patients are taking non-vegetarian diets, they do not develop B12 deficiency unless they have some other abnormality. The second one is very important, that is decreased absorption. Now, this decreased absorption can happen due to various mechanisms. What are those mechanisms? Now, if you understood the mechanism of normal absorption, now you can tell that if the patient has decrease in intrinsic factor, or if the patient has decrease in hydrochloric acid is required for activation of the pepsinogen to pepsin. So if the patient has decreased hydrochloric acid, then also the patient can develop B12 deficiency. Similarly, if the B12 is getting utilized inside the gut itself, before getting absorbed, if it is getting utilized in the gut itself, those patients can also develop B12 deficiency. Next thing is if there is a defect in the pancreas. Okay, pancreatic proteases are required for releasing the B12 from the haptocorins. So if there is a defect in the pancreas, those patients can also develop B12 deficiency. And the last thing is terminal ileal defect. Okay, so if there is a defect in the ileum itself, the final absorption cannot happen. So all these factors can actually lead to decreased absorption. Now we'll see what are the causes. Now, decreased intrinsic factor and decreased hydrochloric acid, these are commonly found in patients with autoimmune destruction of the gastric parietal cells. Okay, so parietal cells are producing the intrinsic factor and hydrochloric acid if there is autoimmune destruction, like in patients with atrophic gastritis. And the classical example here is pernicious anemia. Okay, so pernicious anemia is a condition which will cause this atrophic gastric gastritis because of various autoantibodies. We'll discuss it in detail in the next lecture. So in that condition, this can happen. Similarly, if the patient has undergone gastrectomy, again, they will have this decreased intrinsic factor and hydrochloric acid. If the patient is taking proton pump inhibitors, definitely those patients are going to have decreased hydrochloric acid. Okay. Now coming to increased utilization in the gut, that means B12 is utilized in the gut itself before getting absorbed. So who is utilizing this? So if the patient develops some kind of bacterial overgrowth in the small intestine, if they develop some kind of bacterial overgrowth in the small intestine, those bacteria can actually utilize all the vitamin B12. Okay, so that condition is known as small intestinal bacterial overgrowth, SIBO. Small intestinal bacterial overgrowth. This we'll discuss more when we'll discuss in the GI pathology section. Similarly, if there is fish tapeworm infection, that can also cause this, that can also utilize the B12 inside the gut. Okay, so fish tapeworm is otherwise known as the name for the fish tapeworm is Diphyllobostrium latum. So it is Diphyllobostrium latum. So this is a very commonly asked question: which parasite can cause iron deficiency and which parasite can cause B12 deficiency? Iron deficiency, as we have discussed previously, iron deficiency is caused by hookworm infection, and now we discuss that fish tapeworm infection can cause vitamin B12 deficiency, Diphyllobostrium latum. Okay. Then next thing is pancreatic dysfunction. That means any condition which can cause chronic pancreatitis. So any chronic pancreatitis which will lead to defective exocrine pancreas function can cause B12 deficiency, and the reason we already know. The last thing about this decreased absorption is the ileal defect, or you can say terminal ileal defect. Now, ileal defect can happen in patients with Crohn's disease. This is a type of inflammatory bowel disease. We'll discuss more on this when we'll discuss about the GI pathology. Then patients with tropical sprue. Now we have discussed, when we discussed about the iron deficiency anemia, we discussed that celiac disease. Celiac disease is again a type of malabsorptive disease which predominantly affects the upper small intestine. Okay, predominantly affect the upper small intestine. That means the duodenum. So that is more likely to cause iron deficiency. But tropical sprue is another malabsorptive condition which predominantly affects the distal small intestine, that is the ileum. Okay, so tropical sprue is more likely to cause B12 deficiency. Or if the person has undergone surgical resection of the ileum due to any of the cause, if the patient has undergone surgical resection of the ileum, that can also lead to defective B12 absorption. Okay, so these are the causes which can reduce the absorption of the vitamin B12. Then certain patients have increased requirement for the vitamin B12, like in patients who are pregnant. Okay. Sometimes in patients with hemolytic anemias, they can also develop they can also have increased requirement for this vitamin B12. Okay. So these are the causes which can cause vitamin B12 deficiency. Among these, we'll discuss in detail about the pernicious anemia in the next lecture. Okay. So now that we have understood clearly about the absorption, now we have also understood what are the causes that can lead to B12 deficiency. Now we'll see two reactions in our body which require vitamin B12. Okay, and what are those two reactions? The first reaction we are going to discuss is this. Okay, this is actually a very important reaction because this is the same reaction we are going to discuss for folic acid also. Okay, so this is a reaction which requires both B12 and folic acid. Okay, it requires both B12 and folic acid. Now there are actually B12 has you can remember it has three forms. One is methylcobalamin, which is the major form. Another major form is the adocobalamin, or otherwise known as the adenosylcobalamin, and the third form is hydroxycobalamin. Basically, this methylcobalamin and adocobalamin can be converted to hydroxycobalamin. Okay, this reaction actually needs methylcobalamin. This reaction needs methylcobalamin. Okay, and the next reaction, this reaction needs the adocobalamin, or otherwise known as the adenosylcobalamin. Okay, so let us start discussing this reaction. So basically, this B12 will take up a methyl group. It will take up a methyl group to form methyl B12. Okay, so B12 will take up methyl group to form methyl B12. From which compound it is going to take the methyl group? It will take the methyl group from N5 methyl tetrahydrofolate. THF is tetrahydrofolate. Actually, this is a form of folic acid. This is a form of folic acid which is predominantly present in the plasma. This will also discuss. This will also discuss when we will discuss about the folic acid metabolism. That the predominant form that you are going to find in the plasma is N5 methyl tetrahydrofolate. Okay. Now B12 will take up methyl group from this N5 methyl tetrahydrofolate, and it will be converted to methyl B12. Okay, methyl B12, and this N5 methyl tetrahydrofolate will be converted to tetrahydrofolate. Okay, actually, even though N5 methyl tetrahydrofolate is the predominant form in the plasma, but what body needs is the tetrahydrofolate. Okay, so tetrahydrofolate is the reactive form. I mean, that is the form that is going to take part in the reaction, which will ultimately help in DNA synthesis. Okay, how? Now this tetrahydrofolate can be converted to N5N10 methylene tetrahydrofolate. Okay, this is by help of serine. Okay, this is by help of serine. Serine will be converted to glycine, and this tetrahydrofolate will be converted to N5N10 methylene tetrahydrofolate. Okay, now this N5N10 methylene tetrahydrofolate, this can convert DUMP to DTMP, deoxythymidine monophosphate. Okay, so this is deoxyuridine monophosphate. This will be converted to deoxythymidine monophosphate by the help of N5N10 methylene tetrahydrofolate. And the N5N10 methylene tetrahydrofolate will be converted to dihydrofolate. Okay, so in this reaction, N5N10 methylene tetrahydrofolate will be converted to dihydrofolate, and DUMP will be converted to DTMP. Okay, so this is required for synthesis of thymidine. Thymidine is a component of DNA. So that will help in DNA synthesis. So this is how tetrahydrofolate and also B12 is actually helping in the DNA synthesis process. So that is why whenever we have B12 or folic acid deficiency, there will be defective DNA synthesis. Okay. And also you can understand that both B12 and folic acid, they are dependent on each other. I mean, they work together for this reaction. Okay, so single-handedly they cannot form this reaction unless you have direct tetrahydrofolate. Okay, so direct tetrahydrofolate is not present in our body. In our body, we have N5 methyl tetrahydrofolate, which has to be converted to tetrahydrofolate with the help of B12. Okay, now what happens? Now this dihydrofolate can be converted to tetrahydrofolate with the help of an enzyme that is known as dihydrofolate reductase. Dihydrofolate reductase. Again, this reaction, this conversion of DUMP to DTMP, this is caused by an enzyme that is known as thymidine synthetase. Thymidine synthetase. Okay. Okay. So DUMP to DTMP conversion happens with the help of enzyme thymidine synthetase, and dihydrofolate to tetrahydrofolate conversion is caused by this dihydrofolate reductase. These enzymes are important because there are certain drugs that you have to remember which can actually inhibit these enzymes. So drugs like methotrexate, and trimethoprim. Methotrexate and trimethoprim. These are the drugs which can actually block these dihydrofolate reductase. Similarly, there is another anti-cancer drug that is 5-fluorouracil. You will study more on this in the anti-cancer pharmacology. So 5-fluorouracil can actually block this thymidine synthetase. Okay. Now we'll see what happens on the other side. What is happening on the other side? So we'll see what happens here. Now this methyl B12 can actually provide its methyl group to one amino acid that is known as homocysteine. Now this homocysteine will take the methyl group from the methyl B12 and it will be converted to methionine. Okay. So for methionine synthesis, we need B12. Okay. That is the methyl B12 form. Okay. So B12 will take the methyl from the B12 will take the methyl group from N5 methyl tetrahydrofolate. Now this methyl B12 can give this methyl group to homocysteine so that homocysteine can be converted to methionine. Okay, so B12 is required for methionine. Also, folic acid is required for methionine synthesis. Okay, so basically these folic acid groups, they act as one carbon. I mean, they take role in one carbon metabolisms. Okay, by providing these methyl groups, they take part in one carbon metabolisms directly or indirectly. Okay, so these are also known as the biological middlemen. Okay, so either they will take methyl group, give to someone else. Okay, so they'll take methyl groups, give to someone else. In that process, they help in various methylation reactions. Okay, directly or indirectly. Okay, now this once this methionine is formed, this methionine can be converted to S-adenosyl methionine. So SAM is S-adenosyl methionine. S-adenosyl methionine. This reaction, okay, before that, this conversion of homocysteine to methionine, this reaction is catalyzed by an enzyme that is known as methionine synthase. Okay, MS. I'll just write shortly methionine synthase. Also, this reaction, also it is done by the same enzyme, that is methionine synthase. Okay, this is also methionine synthase. Okay. Then this methionine can be converted to something known as S-adenosyl methionine. Okay, S-adenosyl methionine. Now this S-adenosyl methionine is very important. This is actually very important. Why? This S-adenosyl methionine take parts in various methylation reactions. Okay, so as I have told you, this folic acid, they take role in providing methyl groups or one carbon groups to various compounds for various methylation reactions. Okay, they do it mostly by indirect method. So this is one of the method. Okay, so from the folic acid, the methyl group came to B12. B12 gave methyl group to homocysteine. It is converted to methionine. This methionine is converted to S-adenosyl methionine. This S-adenosyl methionine can actually take part in various methylation reactions, like it take part in formation of epinephrine, norepinephrine. So if you actually study the formation of epinephrine, norepinephrine, or melatonin, in all those pathways, you will see that in the last pathway, they need one methyl group. That methyl group is provided by S-adenosyl methionine. Okay. For us, now, what is important? One reaction is very important to remember, that is conversion of phosphatidylinositol to phosphatidylcholine. Okay. So this is phosphatidylethaноlamine. This is phosphatidylethanolamine. This is phosphatidylcholine. Okay, so why this phosphatidylcholine is important? This take part in myelin synthesis. Okay, so that is why in patients with B12 deficiency, you are going to get this defective myelination. Okay, defective myelination of the neurons can cause various abnormalities that we are going to discuss in the subsequent slides. We'll see how this, what are the clinical manifestations of this defective myelin synthesis. Actually, exactly we do not know what is the reason behind defective myelination in patients with B12 deficiency. We do not know exact mechanism, but this is one of the proposed mechanism. Okay, so this is not the only mechanism. We have various proposed mechanisms also. One more mechanism we'll discuss in the next slide. But exactly which mechanism is causing this abnormality, we do not know. Okay, so basically this S-adenosyl methionine, it will provide its methyl group. It will provide its methyl group to phosphatidyl ethanolamine, and this will be converted to phosphatidyl choline, which helps in myelin synthesis. Okay, so these are all the concepts about this reaction. It's a very important reaction. You have to revise it multiple times so that we'll gain a so that we'll be thorough in this, because this will solve many of our problems in understanding the pathophysiology of B12 and folic acid defects. Okay, there is one more concept I will tell here. That concept is folate trap. Folate trap. So what do you understand by folate trap? Okay, so if you understood this reaction, from this you can understand if the patient has B12 deficiency, if the patient has B12 deficiency, the N5-methyl tetrahydrofolate cannot be converted to tetrahydrofolate. And now we understood that tetrahydrofolate is actually required for the ultimate DNA synthesis. Okay, tetrahydrofolate is the form that we want for our DNA synthesis. But if you do not have B12, this N5-methyl tetrahydrofolate cannot release its methyl group. It cannot release its methyl group. So this N5-methyl tetrahydrofolate cannot be converted to tetrahydrofolate. Okay, so if the B12 is absent, this reaction cannot happen. So that means even in our body we have folic acid, we cannot utilize this folic acid effectively because its conversion to the active form, that is tetrahydrofolate, is not happening. Okay, so if the patient has B12 deficiency, the folates are trapped in our body, they cannot be used. Okay, so they are really useless. So this is known as folate trap. So folate trap is B12 deficiency leading to a decreased utilization of the folic acid in our body. Okay, so this is the concept of folate trap. Okay, so this is all about this reaction. Now we'll go to the next reaction. As I told, the first thing is this will use the adocobalamin form. What happens in this reaction? There are certain odd chain fatty acids in our body. Odd chain fatty acids, whenever there is odd chain fatty acid oxidation, as you know, in fatty acid oxidation, ultimately they will form the acetyl CoA. Okay, acetyl CoA are 2 carbon molecules. Okay, those are 2 carbon molecules. But if the fatty acid has odd chain, okay, so if they have odd chain, when they are getting oxidized, they will produce acetylcholine, but ultimately they will have a 3 carbon molecule. Okay, so they will have a 3 carbon molecule. That 3 carbon molecule is known as propionyl CoA. Okay, so that is known as propionyl CoA. Okay, so odd chain fatty acid oxidation, apart from getting converted to acetyl CoA, they will also produce this propionyl CoA, and this propionyl CoA has to go for further metabolism. And this further metabolism of this propionyl CoA, we need vitamin B12. Okay, and also there are certain amino acids like methionine, isoleucine, and valine. Okay, so there are certain amino acids like methionine, isoleucine, and valine. They also, for their metabolism also, they will be converted to propionyl CoA and they will be further metabolized. How exactly they are metabolized? Now we are going to see. Now this propionyl CoA, first it will be converted to methyl malonyl CoA. Okay, so propionyl CoA will be converted to methyl malonyl CoA. This happens with the help of propionyl CoA carboxylase. Okay, so this happens with the help of propionyl CoA carboxylase. And as you all know, these carboxylase reactions. Okay, so as you all know, these carboxylase reactions, they need there is some technical problem. Okay. So these carboxylase reactions, they need biotin as cofactor. Sorry for the interruption. There is some technical problem. Okay. So like any other carboxylase reaction, propionyl-CoA carboxylase also requires biotin as cofactor. So this requires biotin as cofactor. Okay, so this will convert this propionyl-CoA to methyl malonyl-CoA. Okay, so once methyl malonyl-CoA is formed, now this methyl malonyl-CoA, this will be converted to succinyl-CoA with the help of an enzyme that is known as methyl malonyl-CoA mutase. Okay. Sorry, there is some technical issue. Okay. So this conversion of methyl malonyl-CoA to succinyl-CoA happens because of methyl malonyl-CoA mutage. Okay, and this requires vitamin B12 in the adocobalamin form as cofactor. Okay, so propionyl-CoA will be converted to methyl malonyl-CoA with the help of carboxylase, which requires biotin as cofactor, and methyl malonyl-CoA will be converted to succinyl-CoA with the help of a mutage, which requires B12 as cofactor. In this, the first reaction, it is actually ATP dependent. It needs ATP and carbon dioxide. Of course, the carbon dioxide will provide the carbon group because it's a carboxylase reaction. So one carbon will be added. So methyl malonyl-CoA is a 4-carbon compound. Propionyl-CoA is a 3-carbon compound. This is a 4-carbon compound. Okay. Now this succinyl-CoA can go into the citric acid cycle or the Krebs cycle. Okay. So as you all know, succinyl-CoA is an intermediate in the citric acid cycle. So this succinyl-CoA now can enter into the Krebs cycle or citric acid cycle. So in this Krebs cycle, it depends on what body actually wants. If body needs energy, this Krebs cycle can provide ATP. But if body has enough ATP and it wants to store more glucose, this can also go in the gluconeogenesis pathway. Okay, depends on what body wants. If the body wants energy, they will provide ATP with the help of this Krebs cycle, followed by the oxidative reaction in the electron transport chain. But if the body needs glucose, they'll go in the gluconeogenesis pathway. Okay. So this is about this reaction in which odd chain fatty acid can be metabolized and methionine, isoleucine, and valine can be metabolized. In this reaction, we need vitamin B12 for this methyl malonyl-CoA mutage. Okay. Now it is thought that if the patient has B12 deficiency, this propionyl-CoA can be converted to propionic acid. This propionyl-CoA can be converted to propionic acid. And this propionic acid can actually cause abnormal fatty acid accumulation in the myelin. It will cause abnormal fatty acid accumulation in the myelin. This is one more mechanism why this patient with B12 deficiency will develop myelin dysfunction. Okay, will develop this defective myelination. Okay, this is one more mechanism. So propionyl-CoA will increase and that will be converted to propionic acid that will cause abnormal fatty acid deposition in the myelin cell. Okay, and that will ultimately cause defective myelination in patients with B12 deficiency. This is another mechanism, but as I told, exact mechanism we are not very sure. Okay, and also from this reaction you can understand if the patient has B12 deficiency, there will be increased in methyl malonic acid. So patient with B12 deficiency will have increased methyl malonic acid. And this can be detected in the urine. So methyl malonic aciduria happens in patients with B12 deficiency. This can be found in the urine. Okay, this also aids in our diagnostic clue in patients with B12 deficiency. Similarly, if the patient has B12 deficiency, there will be also increase in homocysteine. Okay, so it can cause homocysteinemia. Okay, and we'll discuss when we discuss about the atherogenesis. This homocysteinemia can actually increase the risk of atherosclerosis. This can increase the risk of atherosclerosis. Okay, so this we'll discuss later, but for now you remember B12 deficiency, there will be increase in homocysteine that can cause atherosclerosis leading to various cardiovascular abnormalities, and also it will increase methyl malonic acid in the urine. Okay, so this is about the reactions of vitamin B12. So this is about the reactions. Now we'll see. I am telling you about the defective myelination. Now we'll see what are the consequences of defective myelination. Okay. So if you have defective myelination, basically in the spinal cord, the white matter tracts, actually the myelinated fibers go in the white matter tract. Basically, this myelin will provide the white color. Okay, so white matter tracts are actually myelinated tracts. So if there is defective myelination, they will affect the white matter tracts that are going in the spinal cord. So what are the tracts that are predominantly affected? Okay, so three important tracts you have to remember. One is this dorsal column. This is the second one is the spinocerebellar tract. Spinocerebellar tract. Third one is the corticospinal tract. So these are the three predominant white matter tracts that are affected in patients with B12 deficiency. This is known as subacute combined degeneration of the spinal cord. Okay, subacute combined. Why it is combined? Because multiple tracts are affected, and this will cause both motor and sensory abnormalities. So that is why it is known as combined degeneration. If there is defect in the dorsal column pathway, as you all know, dorsal column carries the fibers for proprioception, fine touch, and proprioception and vibration. Okay, so there will be defective vibration, and proprioception sensations. Okay, defective vibration and proprioception sensations. If there is involvement of spinocerebellar tract, that will cause ataxia. Spinocerebellar tract can cause ataxia. Involvement of the corticospinal tract, this will cause human signs, upper motor neuron signs. We will discuss all those things more in neurology. I'm just telling the findings. They will have human signs, especially they will have this spasticity, and also extensor plantar. So the extensor plantar will be extensor. Okay, so these are the common findings. Apart from that, they can also involve the dorsal root ganglia. Involvement of dorsal root ganglia can also cause this ataxia, sensory ataxia. It can also cause sensory ataxia. Okay, so these are the findings because of involvement of the various white matter tracts in the spinal cord. Of course, dorsal root ganglia is not a white matter tract, but that can also be involved. It can also involve the peripheral nerves. It can also involve the peripheral nerves, leading to peripheral neuropathy. And in severe B12 deficiency, it can actually involve the cerebral cortex also. In severe B12 deficiency, it can actually involve the cerebral cortex. That can lead to dementia. Okay, so these are the CNS abnormalities in patients with vitamin B12 deficiencies. Okay, and there are various mechanisms. Some of the mechanisms I have already told you, but there are various mechanisms but we exactly do not know what is the mechanism behind this. Okay, so B12 deficiency can cause hematological abnormalities, as we have already discussed. It can cause CNS abnormalities. It can also cause some other types of abnormalities that I will discuss when I discuss about the pernicious anemia. But these are the important ones, hematological and neurological. You need to remember that in patients who develop B12 deficiency, if you give folic acid, if you give sufficient amount of folic acid, it can actually revert the hematological abnormalities. But it cannot revert the CNS abnormalities. That is why in patients with megaloblastic anemia, suspected megaloblastic anemia, we should never give folic acid alone. Because that will actually improve the anemia part, but the neurological part will worsen. Okay, so all these patients has to be given both folic acid and vitamin B12. Okay, and it is also said that around 20% of the patients with B12 deficiency will develop only neurological signs, not the hematological abnormalities. Okay, so around 20% of patients with B12 deficiency, they'll develop only the neurological manifestations and no anemia. Okay, so that is how much important B12 for the neurological system. Okay, so this is about the B12 metabolism, and also we have discussed a lot of clinical points. In the next lecture, we will be discussing about the pernicious anemia, and after that, we will discuss about the folic acid metabolism and the deficiencies. What are the causes of folic acid deficiencies?